Hi everyone, I hope all of you are well. This is the review for the upcoming exam, which is on Thursday at 8. There are 7 topics, 5 questions each, so it's a total of 35 question exam. I thought about putting more questions, but when I looked at each topic, 5 questions were just enough to get to the essence of each topic. I know some of the lectures had a lot of content. Sleep medicine, for example, had close to 4 hours of content. That's because Dr. Cohen likes to go over the big picture with you. There's a story behind all the essential content in his presentation. Even Dr. Doroshenko's presentation, which was a little under an hour, he had a lot of material too. But again, I wanted to just get to what was essential in each topic. So 5 were enough. So first topic, diagnosis, prognosis, and training. Because that was the day when I had to go over the syllabus and schedule a little bit, we only got through House's classification of patient personality, which are 4, as you know, exacting and hysterical. I'll have some scenario like description of a patient, and I'll ask 5 questions on these 4. For the next topic, immediate denture, you should definitely know what options we have in terms of approaching this treatment surgically, whether we extract strategically posterior teeth first and then anterior teeth later, or extract all teeth at the same time. Based on those 2 strategies, you should know pros and cons of each one. In terms of making impressions, you should know that especially if you're thinking about whether you would extract all teeth at the same time or extract in sequences, you should know how your impression making technique can vary. So if you're extracting all teeth, usually you'd be fine with making a full arch impression. Oftentimes, though, patients will have periodontally compromised teeth, especially the anterior teeth, which they don't want to let go yet. So you may consider making a segmental impression where you have the posterior made with a VPS impression material, which may be a little bit more rigid than something like alternate, which you would use then for the anterior teeth. So the impression techniques, you don't use it just because you have mobile teeth, but again, you're trying to be consistent with your surgical treatment plan, whether you extract in sequences or all of them at once. Anterior teeth arrangement, I mentioned during the presentation that we sometimes make the mistake of removing all the teeth from the cast, and as a result, we lose a lot of reference. Therefore, a good way to arrange anterior teeth without losing references is to arrange one at a time, if possible. So this is kind of a very straightforward picture showing just that technique, where we're leaving tooth 9 shaved away 8. And that gave us the midline as a reference, the incisal edge position as a reference, etc. And that gives me a good confidence to place the denture tooth on 8. For posterior teeth arrangement, oftentimes it's affected by occlusion, whether we're talking about the vertical dimension of occlusion or the horizontal relationship, which is often determined by eccentric relation. It's not mentioned here, but obviously that arrangement needs to be in harmony with the anterior teeth. But as far as the arrangement goes for posterior teeth, again, just remember those 2 factors, vertical dimension of occlusion and eccentric relation. A critical part of arranging teeth for immediate denture is modifying the cast. And in the end, we want to really produce a cast that is going to be the closest to the mouth after the surgery, especially on the day of the surgery, because there will be some alveoloplasty done and potentially some soft tissue removal too, if there's excessive soft tissue. Here, it mentions some of the ways to approach that, whether you over trim the cast or under trim. Of course, each one has a consequence. So I'll have kind of a scenario example where, let's say a student decided to provide this treatment for a patient. So on the day of the surgery, patient got the immediate denture. I can mention that, well, denture happened to be very tight, or it was impinging on the soft tissue, leading to discomfort. Why would that be? And you should be thinking about how the cast was trimmed. Another example is patient felt really comfortable with the denture on the day of the surgery. However, it was extremely loose, or it lacked retention. Why would that be? You should be thinking about, again, how the cast was trimmed. Overall, though, we want to be on a conservative side rather than aggressive side, because we have to favor patient's comfort over how tight the denture should be. I had a student about a couple of weeks ago providing immediate denture treatment for her patient, and we worked together actually quite a bit. And in the end, before she had everything sent out to the lab, I, mentioned to her that she needed to really include in the lab prescription that the lab needs to make a surgical guide. And she did that, but during the surgery, she forgot to have the oral surgery use it. So, I'll talk about that. I'll have a question on this topic in the exam too. This is a critical component to the successful surgical part of immediate denture treatment. Probably the most important point in terms of what goes on in oral surgery for immediate denture patients is not to schedule an appointment where you couldn't do a 24-hour follow-up. Now, that's changed slightly with the pandemic going on, but we're still trying to have a 24-hour follow-up. So, to my knowledge, no one has really scheduled any surgical and delivery appointment on Fridays. So obviously there will be a question about that. What happens during those 24 hours, you should know. That was about it for immediate dentures. Now, implant prosthodontics. The first topic was on overdenture by Dr. We don't really rely so much on a two-dimensional radiograph anymore. We really look at cone beam CT scan because it really gives us a three-dimensional imaging of the anatomy, which obviously is far more telling than two-dimensional image like this one here we see. I'm not trying to ask if you know how to look at the anatomy based on CT scan, but here I think it's the third point or second bullet point there is CT scan does allow us to really look at some critical anatomy, whereas panoramic radiograph doesn't. So I guess the second and the third bullet points there. So vital structures, critical anatomy, as well as the dimension of the heart tissue, those are a lot more accurately assessed using CT scan than panoramic radiograph. The numbers, I'm not really interested in testing if you know the numbers, especially how much bone height you should have, how much bone width you should have. That's going to come to you more naturally once you start seeing patients that go through implant therapy. You should, however, know how much space you would need to have for someone going through implant retained removable prosthesis, so implant overdenture. You should know. It should be, we're going to go by Dr. Fay's slide here. We should be at least 12 millimeters. To me, it's a range, but to simplify, I'm just going to ask you this number. Mandibular implant overdentures, 2 implants in the anterior region, that's really enough. In fact, that is far better than a patient without any implants on the mandibular arch. And this was something that was discussed in a very famous conference back in the 70s, I believe, in Montreal, Canada, by Dr. Fine. I don't know if I'm pronouncing her name correctly, but ever since then, this has kind of become the standard of care for edentulous patients and improving their quality of life, especially in regards to the mandibular overdenture or mandibular complete denture. You should know that the implant overdentures, they use a specific abutment type, and it's called locator abutment. It's not called custom abutment or prefab abutment. It's called locator abutment. Now, as for maxillary implant overdentures, there's some unique aspects to it. One is that because the maxillary heart tissue tends to have poor quality compared to mandibular heart tissue, potentially we see a little bit more complications with the maxilla. At the same time, because it's such a broad surface area, we tend to place more than just 2. So if you think about a broad table, large table, you really want 4 legs rather than 2. Couple that with the fact that the bone is oftentimes not as good in terms of quality when compared to mandibular arch. 4 is really the minimum. Now, once 4 implants or more are successfully also integrated in the maxilla, we can really provide some distinct benefits to the denture patient compared to a denture patient who can't afford to have any implants for whatever reason. One of the major benefits from the patient's perspective is we can take away some of the palatal portion of the denture, and that makes it a lot better in terms of comfort and function. So that's what it means by exposing palatal tissue improves food texture, room for tongue. And the rest of it, I think you should know. I'm not really going to go in detail here, but you should really know that when people talk about palateless denture, they're referring to just this, exactly this, because we're able to place at least 4 implants and support the denture properly. With that, we don't need support from the broad palate. We can take away some of it. Now, just a side note, palateless doesn't mean we take away the entire palate. There has to be some remaining because we would still want to have some bulk to the prosthesis. When the prosthesis becomes really small, thin, narrow, we may run out of room to place metal to reinforce it. Even if we place metal there, it just may not be adequate. So palateless doesn't mean it's completely without the palate. It just means less palate. Okay. Apart from what the treatment involves for implant overdentures, you should definitely know about maintenance, because maintenance, as with everything in dentistry, is a key to success of implant treatment here. So just because implants have been placed and they also integrated and patient was satisfied receiving a nice overdenture, doesn't mean patient doesn't need to see anyone. Patient still continues to see someone regularly for maintenance of both implants, soft tissue around them, as well as the denture itself. Then Dr. Doroshenko presented the second topic in implant prosthodontics, which was in all-on-4 or all-on whatever number. So, I realized he had a lot of great content. Some of them were really cool to see, but I feel like maybe I should have had some introduction material before you all went to his presentation. So I decided to put some here. This is not going to be on the exam, but for your information, go over these when you get a chance. I think that even having the introduction now, it will make sense. Now, on them, I basically picked out, again, what was really essential to this treatment modality. One of them is restorative space. So you should really know how much restorative space we need for, let's say, all-on-4 that is made out of acrylic, and that which is oftentimes supported by a metal substructure, and that's what the bar is. When we add them all up, the denture plus the metal bar plus abutment that connects the whole prosthesis to the implant, it's about 15. In the literature, you'll see it's a range. Some people say at the minimum it should be 15, and it can go up to 18, sometimes even more, sometimes even less, but we'll just use Dr. Doroshenko's number here. To create that restorative space, we have to take something away. And oftentimes in this treatment, we do quite a bit of alveoloplasty, and to some people, it's very aggressive. Those people may, if they're conservative, may end up actually compromising the restoration or prosthesis because they wouldn't reduce enough bone, and that limits the space for the restorative material, and that restorative material as a result can be very thin, not as bulky, not having enough bulk. It doesn't have to be bulky, but it has to have some dimension to it. When that happens, the prosthesis can fracture, teeth can come off. So a lot of prosthetic complications can happen when the hard tissue is not sufficiently reduced. And Dr. Doroshenko lists other benefits to reducing bone properly. It's not just to create that space, but there are many other benefits to that. So you should know. Why should you know, especially if you're not going to do this treatment? Well, you're bound to see someone who has gone through all on whatever treatment, bound to see someone walk into your office, especially with some sort of problem. Patient has hard time keeping it clean. Patient has periimplantitis. Patient has tooth popping off. Patient has a prosthesis fracturing, and you want to be able to diagnose the problem, even if you don't want to treat, even if you want to refer the patient to someone who can manage that complication. But by knowing these various reasons why bone reduction should have been done, hopefully you can diagnose that properly and refer properly if you decide to refer. Dr. Doroshenko mentioned a few different ways to obtain CT scan and planning for implants. One of the methods he showed was duplicating a denture using a duplicating flask that you see on the far left side. Use clear ortho resin to make that duplicate denture. Place radiopaque markers such as gutta percha around that clear radiographic denture or template, and have the patient wear during CT scan acquisition, and that shows us where the teeth should be. The important part here is that denture that Dr. Doroshenko duplicated. It's an ideal denture where the teeth arrangement is exactly where you want the teeth to be in terms of occlusion, in terms of aesthetics. Based on that idealized teeth arrangement, we are planning the implant position ideally, hopefully, especially if there's good harmony between the available hard tissue and where the teeth have been idealized by this denture. Another part of diagnosis and treatment planning that Dr. Doroshenko reviewed was the aesthetics. So on the left side, figures A and C, again, you see that radiographic template. On the right side, figures B and D, you see the same radiographic template, but now it has what looks like a silver foil near the periphery of the template in the anterior region. That silver foil corresponds to this patient's smile line, and that's critical during the diagnosis and treatment planning because if a patient especially has a high smile line and ends up showing the junction between the prosthetic gingiva and patient's own gingiva, it could be an aesthetic failure at the end. In other words, patient smiles and shows that junction because prosthetic pink is very difficult to mimic natural pink in terms of color. Then it's going to be very noticeable. So what do we do? Well, potentially this all-on whatever treatment is probably not going to be the best one for patients with high smile line. Or we go ahead and reduce bone beyond that smile line if possible. If possible, meaning after reducing a lot more than what we would need to do, we still have enough bone volume to house implants. If that's the case, then this treatment will work. If we don't have enough bone after reducing that much beyond the smile line, then we shouldn't even go through that treatment. We should think about another type of treatment, such as overdenture, where the denture flange or denture extension will cover that potential junction. So when patient smiles, we only see the denture pink rather than the junction between prosthetic pink and patient's own gingival pink. He showed a few different types of guides for placing implants. Obviously, the implant guide, again, is designed and fabricated based on that ideal denture teeth arrangement. And there are different details to this guide. The openings that you see on the occlusal surface, obviously, are what allows the various implant surgical burrs to create osteotomy or opening into the hard tissue. I'm not sure, I think he mentioned, but just in case he didn't, there are also openings at the lateral aspect of the guide. There are thin pins that go through those openings to fixate the guide in the patient's mouth, and that allows the guide to stay stable while we're placing implants. Because when we place implants, we do put considerable amount of torque, and that could sometimes destabilize the guide. So these pins we call anchor pins really help in that regard. Last topic in terms of presentations by guest lecturers for this exam, sleep medicine by Dr. Cohen. Again, almost 4 hours worth of material, which again is something that you will find difficult to get once you graduate. So I really appreciate every year how he is so willing to review his knowledge in those 2 sessions. At the same time, for not just for exam purposes, but just kind of thinking about what it might be like in our practice. I would suspect most of us won't deal with patients who require intervention or treatment in this area. For that reason, I wanted to at least make sure you know you have some critical information under your belt. So, for example, you should know, why is sleep medicine so important? How do you diagnose issues in sleep medicine? Well, first of all, sleep, it's not, it's a very dynamic thing. There are multiple factors, facets to it. So that's something that we should always, again, wise asking patients about how they sleep. Why is that important? And the various reasons. We should definitely be aware of some risk factors. That way, we can refer patients properly. In my opinion, in our practice, again, unless we go into sleep medicine and decide to be an expert in this area, we should at least be able to recognize that some of our patients are in high risk category, and therefore we are able to refer these patients appropriately. And these issues, what are other kind of dental and facial related risk factors? And he talked about 2. That's almost dental slash basically when we have a retrognathic mandible situation, that can predispose the patient to obstructive sleep apnea. It makes sense to me because it really restricts the space for the tongue. When that happens, tongue can kind of kick back and reduce the airflow. And again, that's one of several risk factors when we're looking at the soft tissue volume. But again, all these go to both hard tissue and soft tissue risk factors, as well as systemic risk factors. They all go to reduced airflow in the upper airway. And in terms of what happens when patients don't receive the appropriate treatment in this topic, we should know, because that way we can educate our patients. Again, we may not be treating them ourselves, but we educate them and again are able to provide proper referral for our patients who suffer from sleep apnea. We should be able to diagnose. I think the key point he made is we as dentists, we don't diagnose. It's based on a study, and that study obviously has an objective way to diagnose this patient's problem in terms of sleep. I included this slide, although it seems specific to pediatric patients, but I think it again emphasizes that we as dentists don't diagnose obstructive sleep apnea. We work with an MD who has that objective diagnostic tool. I also wanted in this slide because there are other people involved in management of sleep, obstructive sleep apnea, and we should know again because these are potential people that need to be involved in this team in order to successfully treat patients. How do we treat patients? Well, he talked about 4 ways basically. You should know that. Among those 4, he talked about various devices to provide treatment. And I picked these because, again, as a prosthodontist, I'm always looking at designs of devices. He talked about mandibular repositioning devices because all of them may look different, but they all have the same goal, which is to try to advance the mandible. Again, it makes sense to me that, especially for retrognathic patients, by advancing mandible, we're creating a little bit more room for the tongue, and hopefully that would reduce blockage or reduction of airway, airflow in the airway. But also tongue retaining device, instead of trying to advance the mandible, well, why don't we try to keep the tongue in more anterior position than posterior? Again, they will achieve the same, hopefully, goal, which is to allow airflow through the upper airway. There are 6 key actions for both maxillary and mandibular arches when we are doing border molding and impression making. You should review those because I'm going to skip all those that I included in this review so that you don't have to go back to the PowerPoint presentation for anatomy. Let me test it on muscles. Actually, I'm gonna have to click. Give me one moment. I can jump quiz review do it, I'll also tell you what kind of questions you should expect on this topic. There are two questions that a significant number of you missed. For that reason, those two questions I threw out. After doing that, I got the lower histogram. So let's see. The first one, most of you got it right. This was one of the two questions that I threw out. I was hoping most people would pick B, at least, orbicularis oris, because in order to create suction around the finger or concentrate handle with the lips, you have to use the muscles around the lips. So that's orbicularis oris. If you did a little looking up, buccinator also can contribute to this action, because with buccinator, our cheeks will get close to the buccal surface of the posterior teeth. But thinking about that, I realized most of you probably wouldn't look anything up, or I'm hoping you didn't, because this for the spirit of quiz or assessment. Even if you did, you might still, you may not be convinced that buccinator is really involved here. But anyways, for these reasons, I just decided to throw it out, meaning everyone got it. People didn't seem to have a real issue with this question, and this question was the other question I threw out. I was hoping most people would pick risorius, because that's the muscle that will pull the commissures or the angles of the lips laterally when we're smiling or saying E. Now, I had to really think about levator labii superioris or angulioris. I guess when I'm really happy, my lips would, upper lip would go up, and as well as my the angles of my lips. But I thought that was debatable. I don't know. I just, for me, I find smiling. I just don't see my lip and angles of my lips going up much at all. But that's just the way I smile. Again, I'm not trying to argue that my way of smiling is right and your way is wrong. So if you pick those answers, well, I threw this question out, so everyone got it right. I'm going to try to provide, at the end of the course, muscles that are really involved in smiling, and hopefully they'll give us a little bit of clarity on this topic, especially regarding this question. Most people did well on this question. Sammy, 100%, 2 in a row, and then one person got it wrong. But again, you guys did all well on house classification. Hopefully, you'll do the same in the clinic. Again, fine. Not bad here. Actually, I have to correct myself here. This was the third question I threw out, not because we had a significant number of students. Most of you did okay. I had a typo here. Up, it's supposed to be 1/2 to 2/3, and I put 1/3. So I threw this question out as well. So going back to that slide where it said 2 questions adjusted, I meant 3. This is a slide that actually says 2/3. Again, people did well here. Question 5. Again, we are not okay. Bad. And overall, I apart from some of three of those questions not being perfect, I thought we all did fine, or you all did fine. And you did even better on the second one, which was. And again, you can review the slides in terms of what you need to know. Especially Hannah's Quint. I have many slides here, I think more than 30. Just kind of, again, reviewing what happens when one out of these five factors changes, whether it goes up, whether it goes down. You should really know. In terms of the questions on this one, what I'm going to do, I might put an actual number. I might say, this patient's condylar inclination is 30. What would happen if the incisal guidance was 40? Something like that. If you understand this formula, as I said, it's not a perfect numerical formula where you can put numbers in and you get some sort of value that's clinically relevant. But you should still know with values you can predict what's going to happen. So let's go back to that example. Patient's condylar inclination is 30. If the incisal guidance that I give the patient is 40, 40 being greater than 30, that incisal guidance is going to override condylar inclination. Therefore, in mandibular movement, the posterior teeth will separate. Now, I can ask a follow-up question where, how do I then manage that problem? Well, either I reduce that incisal guidance, or I change one of the three: plane, cuspal, and compensating curve. So that's kind of the questions that you have this time on the exam. Now I'm going to skip to quiz. I'm sorry, I'm kind of jumping back, I'm going to jump back to the anatomy because I forgot to mention what kind of questions you'll have. First, you should know the actions for each arch that you would do during border molding and impression making. This time, I'm not going to say, which muscles are involved in producing a smile or creating suction around the finger. I won't do that this time. So anatomically, most questions will focus on what kind of actions you would need to do, not an actual testing of do you know which muscle is involved? Because to me, that's just sometimes just memorization rather than do you know what you actually do with the muscle? Okay. As I said, this assessment everyone did much better. Really didn't see here. I really didn't have to throw out any question. I think the only thing I forgot to do was to provide a space for you to put your S numbers. Other than that, I thought the questions were pretty straightforward, and again, you all did well. Okay, well, I hope this review was helpful. It was a little over 45 minutes. All the slide presentations you have, whether PowerPoint or PDF, I think they do provide nice background, nice story for each topic. You really don't need to go back to them. By now, though, I think most of you were at each presentation, and on top of that, you probably reviewed the recordings again. Great. But in terms of studying for this exam, you really don't need to go back to any of that content other than just looking at this review, because I pretty much, all the exam questions will come from this review. Nothing, I won't use anything else. At any rate, I can't believe it's 3 a.m. I gotta go record for the D2 class because they're off again this week. Anyways, thanks for watching. See you on Tuesday.